Well, thank you very much, eEANO, and thank you to Laurie for the introduction. It's been a bit of a long afternoon so far, so I hope you'll bear with me. Just one more to go. My name's Sara. I'm a speech and language therapist with a special interest in neuro-oncology, and I'm a clinician, not a researcher, so I work full-time as a clinician in St Bartholomew's Hospital in London, and neuro-oncology is a part of my role there as an oncology SLT. But today I just want to talk very briefly about the role of SLTs in adult brain tumour populations. So I'm aware that in different countries, speech and language therapists have very different training and different roles. So I thought it might be helpful just to explain. Sorry, let me just get rid of this at the side. Again. Okay. To explain the training in the UK, to give it some context. So to be a speech and language therapist in the UK, you either complete an undergraduate degree of 3 or 4 years or a 2 years master's degree. Both routes lead to the same qualification and cover all aspects of child and adult communication and swallowing disorders. And the graphic here just illustrates the working environment of all SLTs in the UK, whether that's working with adults or children. Oh, why haven't you gone? Oh. There we go. Let's try that one. I'm sorry about that. So why do we need SLTs in neuro-oncology? Well, looking at the highly complex symptom profile is quite a good place to start. So this data is from adults that are self-reporting symptoms using the MD Anderson symptom instrument for brain tumours. And it looks across the disease pathway from newly diagnosed to follow-up. And as you can see, there's a huge range of symptoms, and more than 50% of patients reported at least 10 concurrent symptoms. But if you look at those directly related to SLT, we've got difficulty speaking here, which is about 15%, and we've got difficulty understanding, which is about 10%, but no mention of dysphagia. Looking at a different set of data, this time it's from assessments by healthcare professionals rather than self-report. We can see a different symptom profile. Here it gives a prevalence of 27% for dysarthria, which is a motor speech disorder causing the slurred speech, 24% for dysphasia, but no difference between receptive and expressive, and 26% for dysphagia, or a swallowing difficulty. Now, I believe these values are likely to be an underrepresentation of the problem. Data collected at my previous trust, where we began screening patients for cognitive and communication deficits prior to the initial oncology consultation, showed that over 1/3 of patients had impairments at understanding spoken information just at single sentence level at the start of the disease pathway. So why the discrepancy? Well, people with communication difficulties are very often excluded from studies and even self-report data due to their comprehension impairments. It means they're not able to understand consent agreements, or often not even the self-report questionnaires. So we know our patients have complex symptom profiles, including communication and swallowing difficulties. But what does this actually mean for them? Well, eating, drinking, and communicating are absolutely fundamental to daily life. When was the last time you went through a day without doing all these things? And so here are some of just some of the impacts of the impairments in these areas. If you're looking at the medical environment, we talk about shared decision-making in healthcare. But how can we do this if we don't know the communication function of our patients? And it's just involved in so many areas of day-to-day living, work, social life. But especially for our high-grade patients, it's really important for end-of-life discussions and preparations, whether that's writing wills or letters to loved ones. And swallowing is about so much more than nutrition. The impact of dysphagia on social interaction and self-esteem is significant. So all of this leads to a significant impact on quality of life. So what can we do to help and support people with a brain tumour? Well, we can start with assessment, both objective and functional. We can inform the patient, the caregivers, and the whole multidisciplinary healthcare team looking after these people of what these results are. But really importantly, we can give functional support and therapy. Different approaches for low grade and high grade, but definite roles in both. And also we can educate, but we need to look beyond the patient, caregiver, and MDT to a broader audience. So if we look at assessment briefly, for an SLT, objective assessment using validated tools, they're really important for baseline measures. We're involved in awake craniotomies where surgeons will be working close to eloquent language areas. So we need that baseline function before we start. And the SLT are involved in evaluating language function during the surgery. But baseline assessment is also really key to inform support and identify change. Functional assessment in home and work environments is used to help identify functional goals with the patient. And although swallowing difficulties are not so prevalent in this population, objective assessments such as video fluoroscopy or FEES is still really useful with the right patients. However, functional assessment is often more widely used, especially at the end of life phase when swallowing difficulties often develop. Informing patients and caregivers of assessment findings is key. It allows them to adapt and prepare. It allows them to prioritise and to manage expectations. Informing all those involved in the patient's care of any communication deficits is so important to enable optimum participation for the patient in their treatment and care decisions. Please remember, a language impairment does not equal a lack of capacity. So if I had a clinical conversation, for example, about diagnosis and treatment options in Danish, which I don't speak or understand, I wouldn't be able to participate. I couldn't weigh up information and I couldn't make an informed decision. Does that mean I don't have capacity? Or does it mean the information needs to be presented in a different way? There's also some considerations to sharing this information. They're not easy conversations, and not all patients want to know the information, and we must respect that. Now we come to support and intervention. This is just so important. I'm passionate about providing this support and intervention because we can't assess patients, identify deficits, and then not provide the support that's required to maintain or improve function and quality of life. There are so many ways SLTs can support communication deficits, and just a few are listed here. The approach is going to vary depending on the prognosis and the disease stage. For those with rapidly progressing high-grade tumours, the focus is often on communication partner training, adaptation, and functional support such as AAC, which is things like picture charts or something more technical. For those with lower grade tumours and good prognosis, restoration of function is more of a focus. A more traditional direct therapy may be used, but always working towards functional goals. For swallowing difficulties, texture modification may often be used as a patient deteriorates to allow ongoing pleasure from eating and drinking, whilst reducing but often not eliminating the risk. In other patient groups, swallow rehab may be more appropriate. Again, a part of our skill set and informed by our objective instrumental assessment. For education, I really believe we need to think beyond the patient, caregivers, and their healthcare MDT. Clearly, that's really important as they need to fully understand how we can help and support. But we need to educate commissioners of healthcare services as to our role and value. That way, people with brain tumours will have access to our services. We also need to educate funding bodies to enable badly needed research, providing a more robust evidence base for our role and intervention within neuro-oncology. Quite a big ask, I know. I thought I would finish with a very quick case study of a gentleman who's quite typical of the patients I'm involved with. So this is his presentation history. A 68-year-old gentleman with a left temporal occipital GBM. He had a very supportive family. Sadly, it was 3 months from onset of symptoms to his first scan, but then everything moved very quickly. Note that in August 2021, the expressive dysphasia worsened, but it was prior to any progression being seen on the scan. And it just shows the importance of close monitoring of functional performance. So this was my intervention. I was involved in his initial oncology consultation to observe, where he was functionally fully able to participate. We then run an AHP clinic for similar reasons to Aoife explained in her therapeutic radiography talk earlier on, that it gives us time to actually answer more questions and away from that initial stressful environment. But we also carry out some assessment there. And this assessment identified mild expressive dysphasia in spoken and written modalities, mild receptive dysphasia in spoken modality. The patient was really keen to have some direct input to try and maintain function, and identified maintenance of family names and place names as most important to him. And he worked incredibly hard on that, and it did really make a difference to him. Also, there was the introduction and practice of strategies to use when having word finding difficulties, practicing these so that when the word finding difficulties became worse, the strategies were quite embedded. But also, really importantly, discussion around likely deterioration of communication over time and the need to ensure affairs are in order prior to deterioration. This might be writing letters to loved ones or making sure the will is complete. Regular reviews and support of practice and strategies throughout treatment and monitoring phase took place. But with deterioration, the patient was unable to access communication charts with poor object and picture recognition. So the focus was on advice to family. Regular reviews for dysphagia, which had developed towards the end of his life, were managed by diet and fluid modifications. It enabled him to keep eating and drinking small amounts, almost right up to his final days. He also needed to actually taste each item, as he couldn't recognize it visually, and that resulted in frequent refusal and real upset for the family. But being able to give the high levels of support to the family at this time really supported them with this. In the UK, SLTs are often not involved in palliative care teams, and community teams are unable to respond quickly enough. So I was lucky in my role that I was able to support all the way through from diagnosis to end of life. The patient passed away peacefully at home just under a year after diagnosis. That's a bit of a sad way to finish, but I think it hopefully illustrates the role that SLTs can play all the way through the patient journey. And I hope that gives you a brief insight into the role of SLT in neuro-oncology. Thank you so much for listening.